Where does it even say erectile dysfunction? Did I imagine that? Oh, interesting. Okay, so what do you give for erectile dysfunction? You give it a series of drugs, but they all have it's tadalafil. Those the field drugs, right? They're all phosphodiesterase 5 or not 5. I don't know what the number is, but they're all inhibit this. What does this enzyme do? So when you produce CAMP, right, an enzyme phosphodiesterase breaks it down to nothing, right? I don't know to what, but I think it's just to AM, whatever, right? Now, this if you block this, you're increasing CAMP if you or and CGMP, okay, and this causes vasodilation, right? That's in fact how the tadalafils, all the phosphodiesterase 5 inhibitors work. Now, depending on what cell this is working at, you'll get different symptoms, right? So if it's working in the platelets, for example, you have platelet inhibition, right? What is that good for? That's good for example, there's one that's good for claudications, right? If it's in platelets, so it inhibits platelets. So if you have peripheral arterial disease, that one's good for claudications. If it's happening in the cardiac myocytes, it increases CAMP. It inhibits and increases how hard the heart contracts. So it's a good inotropic agent, right? But in this case, we're talking about the vessels. It increases CAMP, CGMP, right? That is also increased by nitric oxide, if you remember, right? And what it does is it activates protein kinase G. And protein kinase G kind of relaxes the muscle, right? It does the opposite of myosin light chain kinase, right? Myosin light chain kinase contracts the muscle, the smooth muscle. We're talking about the smooth muscle here. So with these drugs, you can't really give nitric oxides and all of things because then you get really, really high CGMP, cardiovascular collapse. The vessels will dilate too much, blood pressure drops, you'll lose pressure to the brain. Interesting life. All right, I'm always being laggy today. 30. Let's see if I. Um, hmm, Let me see. 1 second. Okay. Okay. Let's just go. 36-year-old, 2-week history of palpitations, dyspnea, whatever. Uh, Asthma, frequent throat infections. Immigrant from India. Okay. It's probably a pulses. Okay. Heart murmur. It's probably a rheumatic fever disease question. Right. What does rheumatic fever lead to later in life? Well, I guess this question isn't about that. It's about adding myocytes in series. So series, I remember the E, like eccentric. Also, these are both normal myocytes, and then I'm gonna draw the changes. If you add in series means like in a row, right? If you add stuff in series to this, it's gonna get dilated. It's gonna get bigger, right? But if you add stuff in parallel to it, it's gonna get like thicker because they're like in parallel, right? These are in parallel. So if you add stuff in parallel to it, it's gonna get thicker. So this is series. Eccentric is this. What is it? What's the other one? Eccentric and concentric. This is concentric. Is this? This is parallel. Right. I don't like memorizing. I just remember the parallel. So the fibers are parallel to each other, so it gets thicker. Series are in a row, so they're like the ventricle is like still thin, but it gets bigger. Right. Hmm. What antihypertensive good for preventing this? Oh, it's C, isn't it? Sartan. Sartan. What is it? This is not the right answer. Yeah, okay. No. See, this is by 9%. It's not the right answer. What are sartans? They're vaptans. They're ADH antagonists, right? So that's not the answer. Clonidine is alpha 2 agonist, right? Alpha 2 is an inhibitory receptor. Clonidine um, decreases its activity or agonizes it. So you have central antihypertension. The answer I think is C. And this is a good question, but I think I've mentioned it before in this video series. When you have a diseased heart, several things. So when you have a diseased heart that's not pumping enough, right? Several things will contribute into kind of making it work harder, right? And those things that try to make it work harder will make your heart less healthy, and they'll make it kind of like they damage it further, right? What are those couple things? Angiotensin is one of them. So your kidneys are like they're like we don't have enough blood. They make a signal called angiotensin. Well, they make renin, but renin turns into angiotensin that tells the heart like beat harder, right? Another one is what? Another one is kind of like catecholamines, right? So this is like epinephrine and then your norepinephrine. Okay, so what are the other things? Aldosterone is one of them. All these things kind of like are evolved to make your heart get bigger because your body's like we're not getting enough pressure basically. Um, what else? A bunch of other things, right? But these are the important ones. So when you have like a problematic heart, you want to kind of block all these because they're gonna make the heart, they're gonna cause actual remodeling of the heart tissue, and they're gonna destroy the quality of that heart, and they're gonna make it even worse. So when you're talking about longevity in a person with heart disease, you really want to block all these. What does each one gets? How does each one get blocked? Catecholamines are blocked by um, kind of like beta blockers, right? The most important one to block is angiotensin. It is blocked by ACEs or ARBs, right? And aldosterone is blocked by what? It's blocked by spironolactone. Or like your there's another one. What is the other one? I don't know. If I see it in a question, I know, but these are the important ones. So these three are good for like preventing myocardial reprogramming and like changes in the myocardium, stuff like that. The best one, most important one is angiotensin. That's why we kind of like use some of these after stroke, after like a heart attack, especially this angiotensin blockers. Okay, let me do this because I feel like a lot of people don't like, for whatever reason. Actually, I know for what the reason is they don't understand the concepts behind like these medical concepts, and they like when they get a hard question that like kind of like tests understanding and not like what happened. That not the memorization, they kind of like have a stroke, and then they complain about like, oh, these are just bad questions. They're well, understand what's going on behind. Don't try to like get the question right without like knowing what's going on. Oh my god, what the frick? And then you'll be able to solve these questions. Yeah. So, um, and also don't get sad when you don't get questions right. Don't. What's wrong with you? What's wrong with you? This is shit. Work. Oh, okay. It didn't like that I zoomed in, so I'm gonna try to do it zoomed out. But I'm just realizing I'm wasting a lot. Anyways, it works now. Okay, 10-year-old girl takes amoxicillin, begins vomit. Okay, allergic to amoxicillin. So, and then you give him epinephrine, like in an EpiPen. How does the heart react to it? So it's just this like all the fucking story about the allergy and stuff is like not relevant. We're talking about epinephrine. How does epinephrine change? How does epinephrine change or something? So epinephrine binds beta 2 and alpha 1. In low doses, it's gonna like more beta 2 focused or like it's equal, but in high doses, as in a like EpiPen that gives you a shit ton of dose, it's mostly alpha 1 activation, right? So how does the heart rate? The heart rate goes up. Heart rate is sorry, and also it activates beta 1, right? Heart rate goes up because it activates beta 1, right? Now the question is, do you get reflex bradycardia? Uh, it's a really good question. I don't know. Let me think. Probably. Even if the question says no, you probably get it. Because look, like this is really, I don't know. It's like a balance between the two, I guess. So, but I would be like, I can't eliminate anything from here. Shit, I gave you that speech about like understanding the concepts and stuff like that, but this is has really gotten me thinking actually. But oh, actually, you can just answer it based on this, right? Just based on this alone. Your alpha one, like this is alpha one dominant in the vessels. Otherwise, it wouldn't cause vasoconstriction. It would cause vasodilation. Says B is right, but it's wrong. I can confidently tell you it's wrong. I don't know about these guys, right? But I can tell you, preferably it has to increase peripheral resistance. Otherwise, it's not helping the blood pressure. You need vasoconstriction now. That's why you give a high dose. So your alpha needs to close, right? Okay, 45-year-old man, follow examination, diagnosed with type 2 diabetes mellitus, hypoglycemia, and hypertension. Uh, you give him a second drug. Has diabetes. Okay. Mm-hmm. Okay, so you want something, give him something else that also decreases LDL. Okay, let's talk about these options. This is not my strongest suit. These drugs are a little tricky. This is fibrates. They PP like they activate a like a proxisomal something thing in the cell. The activator transcription factor. It ends with alpha. There's the alpha type and the gamma type. This one does the alpha type, right? It increases the lipoprotein lipase, right? that basically when the chylomicrons and stuff like that, they go into the peripheral tissue, they release it, helps them release more fat, right? Helps them release more fat. It's kind of like insulin for fats because it extracts fat from blood into tissue. That's what it does. So it's really good for decreasing um, your like your um, triglycerides, right? Uh, B, prevention of cholesterol absorption within the small intestine. That makes a lot of sense. C, prevention of enterohepatic circulation of bile. Makes sense, right? Uh, E is already our drug that she's on, right? Is already E. Out of all of these, I want to go with C, but no guarantees. It might be B. Probably B is more, they both work. Like they both work. But maybe B is like more considered like a better treatment. Uh, it really depends on what other comorbidities the patient has. But yeah, only a lot of people know this. So know that this is a drug that starts with E. I don't know what the name is, but it also causes hepatitis. Uh, these are good drugs. The problem with them is I think they cause, you can't use them alone. You have to use them with statins. That's why I went with this because with statins, they work really well. These guys also fibrates cause gallstones because of activation of the alpha transcription factor thing. All right, 87-year-old. I'm gonna close some of these tabs. I know Chrome is probably eating into my computer's RAM. Close it. Okay. But I want to close this guy too. I'll close Anki too. If you want to get your Anki set up, watch the Anki video I have. Also, make sure you're using On King and not just any random deck that some guy made. Use On King that the entire country is using. Yeah, it's a little harder to find where things are, but like, so what? Find it. It's much better than anything else. 87-year-old, palpitations, whatever. EKG is performed. AFib, ER, drug prolongs QRS and QT. Okay, because she's rushed into ER, collapse in the street because of torsada point. Treated with magnesium. I guess this question is going to answer the question about that, what drug you give that treats the magnesium intoxication, or that's treated with magnesium. So increasing QRS and QT, right? These are class ones, right? So you are out. This is a class 1B. This is a C, and this is an A, right? Let's draw our diagrams. This is for B. Okay, let's draw a normal actually first. Damn it. Why don't you already know what I want? Why? Because you had AI powers. Anyways. Okay, normal is comes up. Okay, let's say this is normal. Right. Uh, the answer is not B because class Bs they do this. They make it, and they kind of make everything shorter, right? So it's not B. And then let me show you what A looks like. A is kind of like both fronts. Delay here and delay here, right? So it makes sense that it does both of them. B, on the other hand, is kind of like, sorry, C, on the other hand, is like this. Okay, now now I can't tell you if it's A or B. I think you gotta look at the magnesium, right? But I'm gonna go with A because C is really like rarely used. Yeah. The other thing is QRS and QT. So QRS is kind of like here. QT is kind of like here. Okay. So if you go back to my drawings, you'll see that the one that prolonged both was A that looked like kind of like this. Anyways, my computer is lagging, but A was like the one that had like a delay in the initial phase and then a delay in the second phase as well. C was the one that only had delay in the initial phase, right? Oh, and then so magnesium. Oh my God, I don't know what is wrong with you. The problem is, but it's not switching into. So many goddamn questions. My entire day I want to do this shit, apparently. Okay, whatever. Get rid of this shit. Um, so, I already saw the answer is conivaptan. I already explained to you that conivaptan, the ones that end with vaptan, are ADH antagonists. So this guy probably has too much ADH. What are the causes of having too much ADH? I already see something like a tumor, right? Small cell carcinoma of uh, the lung is one of them. Okay, I'm not gonna spend a lot of time here. So let's look at this. 7-year-old, shortness of breath, heart failure, edema on the feet, has respiratory problems, has atherosclerosis of renal arteries. That's probably what led to all this. Okay, I think I have everything. So, renal arteries are atherosclerosis. There's atherosclerosis in the renal arteries. It means there's not enough blood going into them. Then they're starving of blood. What do? They release renin. What is it talking about? The consequence of what are the first line? Oh. Okay. ACE inhibitors. What are the contraindications? One, if you have the kind of hereditary angioedema thing, right? ACE, the enzyme ACE, right? It breaks down bradykinin, right? That's one of the things it does, right? If you block it, you have a lot more bradykinin. Now, the hereditary angioedema people, they don't have, they have more bradykinin than normal. Why? Because another protein somewhere else that its job is also to break down bradykinin is not working, right? So it has high bradykinin, okay? You get that? So they get angioedema normally. So if when they get ACEs, they just get a lot more angioedema. Angioedema is a dangerous kind of thing. You don't want to have it. So that's the one contraindication. No, shit. Number two contraindication is when you have bilateral renal artery stenosis, because then your ACEs decrease the type of the blood that your kidneys get, right? Because they contract the efferent arteriole. So the overall blood your kidneys get decreases. So if this guy has bilateral bruits over the renal arteries, so if you have that, then your kidneys already aren't getting enough blood because the vessels are getting tightened, right? So it's basically the question wants you to get to ACEs, right? And then what did ACEs do, right? ACEs block. So let's draw the sequence of events, right? You have renin. Renin goes where um, renin activates angiotensin 1. The angiotensin 1 goes to the lung and activates the angiotensin 2. Angiotensin 2 goes to the adrenals and produces aldosterone. ACE is here. No, sorry. ACE is here, right? The ACE the enzyme. So ACE inhibitors inhibit that spot, right? ARBs work here. Also, aldosterone like does its stuff, right? Spironolactone blocks aldosterone stuff, right? So when we block here, we have everything past here is low, everything before here is high. So your renin is high, your angiotensin 1 is high, angiotensin 2 is low, okay? So angiotensin 2 is low, so we got this one, honestly this one, and your aldosterone is low, so your answer is C. Why do I even do this? It's kind of boring to me. This is why I stopped making videos, it's really boring. So I don't like these questions. I'm probably gonna get into tutoring, honestly, because it just feels like I'm talking to no one like this. Also, I'm not making any money. Tutoring, I'll be making money. 7-year-old, the hereditary lipid, LDL is high, right? What treatment do we give this kid? Probably A. I don't know why. They don't take this question seriously. Laugh to its face, to its face. Don't take any questions in general that they don't give you like good explanations seriously. Don't do questions that don't have good explanations in your life. That's my word of advice to you. Questions that don't have explanations are usually shitty. You need the question explanations to learn them. I'm kind of providing that, but I didn't write these questions. I don't know what they're thinking. Some of them are based on SU like slides. Like some of them are focused on unimportant stuff. Also, like I don't know. I'm used to more step style questions. These questions are kind of random style questions. So you got an old guy. Everything's yellow. Okay, probably digoxin toxicity. Which of the following would not exacerbate the toxicity of this antiarrhythmic? Digoxin is not an antiarrhythmic. But okay. So digoxin is eliminated through your kidneys. So A would actually cause a digoxin like toxicity. Clearance C would also cause digoxin toxicity. Hypokalemia causes digoxin toxicity. Digoxin. Hypocalcemia and we got amiodarone. It also causes amiodarone also causes toxicity. It's hypercalcemia. So important things to know about digoxin. First, it's eliminated by the kidneys, so you need to have proper kidney function for it to work, for it to get eliminated properly, for you to be able to dose it properly. Otherwise, it's like the doses you can't control it. And for digoxin, you need to control the dose really really well. Amiodarone, a bunch of drugs basically displace digoxin from the tissue that they're on, right? Because they're I don't well I think they displace it from like the plasma proteins or something like that. Amidronate is one of them. Calcium channel blockers in general is one of them, right? So keep that in mind. Uh, yeah. So hypokalemia also because the channel that the digoxin inactivates is a sodium potassium exchanger, right? So on the extracellular space, it binds to potassium, right? If you have high potassium, it's kind of competing for that, so the drug isn't as effective. But if you have low potassium, the drug becomes super effective, right? So low potassium leads to digoxin toxicity. Now, digoxin toxicity leads to high potassium. If you think about it, it makes sense. I already explained why low potassium leads to digoxin toxicity, because on the outside, if you don't have a lot of potassium, digoxin is just binding to that receptor unopposed, and it's working more, so you get toxicity. Now, what does digoxin do? It inhibits a channel that takes potassium from outside to put it inside. So if digoxin kind of is overactive, all the potassium stays outside of the cell, you get hyperkalemia, right? 27-year-old has had some kid, delivered one kid. That's what this means. 24-year-old pregnant. Also, this doesn't, to my knowledge, this doesn't make sense with the vignette question. It needs to be G2. It means she got pregnant twice and delivered once, right? Because she's also pregnant now. Who writes these questions? The answer is like very old, like years ago, term fours, term fives. But also I could be wrong about this. So anyways, 27-year-old is pregnant. Let's say what else is going on with her life. LDL, HDL. Doctor prescribes a drug of choice for the patient's condition based on their presentation. Oh, oh. I think the only thing that you can use while pregnant uh, is the stuff that stays in your. So okay, all the drugs are pretty bad for your baby, right? They're messing with like cholesterol synthesis, right? Except for the one that doesn't get into your body, which is the one that binds the bile acids, basically the bile acid resins. Okay. Kind of same concept with anticoagulants, right? A little bit of the same concept with anticoagulants. All the anticoagulants are fucking horrible for your baby, except for heparin. Because heparin really doesn't get out of the blood. It's just like there. It's like in your blood, not letting things coagulate. If it's a big molecule. So heparin is the only thing you can use for pregnancy. 60-year-old man, raised to left jaw. So it's kind of an MI situation. Stable angina, hyperlipidemia. Ventricular fibrillation. Okay, interesting. Binds sodium channel. Okay, something that binds sodium channels. Stable angina hyperlipidemia. Okay. I can tell you it's not class C, right? Because class C you need a healthy heart for. You can't have hyperlipidemia. If you have hyperlipidemia, or if you have an MI, okay, it's class B, right? This guy's I zone out for a bit. So class A, B, C. C, you need a healthy heart for a heart with no like atherosclerosis, no like um, definitely no ischemic problems. B is good for ischemic problems. B is really good for ischemic problems, right? So also, let's review. Normal was this. B is like this, right? So QRS is corresponds to this, right? QRS is like kind of extended, I guess. QT is decreased. Phase 3, I'm gonna go with C, but it could be wrong. It's E. Yeah, I don't know what phase 3 of action potential means. Oh, I guess it's talking about this. I don't know. I thought that was QT. I don't know. But these two I can tell you. These questions never show up on anything that is super hard antiarrhythmics. But it's good to know them. Actually, let me just explain antiarrhythmics to you. The class ones. Actually, I'm going to explain all classes. But class 1, class 2, class 3, class 4. Class 2 is beta blockers. Class 4 is calcium channel blockers. Beta blockers, they block beta stuff. So okay, so these two and 4 work in your pacemaker cells, right? Pacemaker cells, this level works with sodium funny channels. This level works with calcium channels again and potassium channels here, right? So the calcium channel blockers block this, right? The the beta blockers, they kind of like extend this phase and this phase. This is a 0 phase, right? The rapid influx is 0 phase. This is 4 phase. This is 3 phase. So 4 or 3. Now 1 and 3, one has A, B, C, D, A, B, C, right? Again, B is for ischemic hearts is really good. It kind of like makes everything shorter, right? A is kind of like um, this is normal. A makes it look like this, right? Extends both. C is not is indicated in ischemic ones, right? And it looks like so it doesn't make a change here, but it makes this extended. Again, this beginning part is a QRS. This end part is a QT. So these two QTO, they make QT go high. This doesn't. Type 3s, they block the potassium channel only. So it's like it goes up normal, and then it's like takes more longer than normal to depolarize. They also increase QT a lot. The good exception here to know is amiodarone. Amiodarone does everything, does a little bit of everything. So amiodarone, when like a lot of times you see a question, it's like, what like class 3 antiarrhythmic is it that like doesn't cause point as hard as all the other ones, or has a little bit better side effect profile as the other ones? Is amiodarone. There's also this one, I think we saw it. The one that starts with S is Sabitol, some shit like that. It starts with S and ends with all. This is a class 3, but it's also a beta blocker, so it has class 3 and 2 activity, but it's categorized as class 3. God, I always regret doing these because it takes such a long time. And the questions are shit. They're poo-poo. 48-year-old, losing income, VWP syndrome. You always give prokinamide for VWP syndrome. Prokinamide is a class 1, so the answer is A. Is it class 1A? What? Okay, is it? Okay. They both, so A and C, I haven't read the other ones. They both are described. Anyways, they both are describing the right things. They're both describing, I think, like a class 1 antiarrhythmic. Uh, but really, how it helps is because it. Oh wait, we got something else. Alright, so yeah, you use procainamide to treat them, but what really like screws them up is a beta blocker, right? So this guy the medication was the wrong medication, right? You give him procainamide. Procainamide explains A is explained by A, but C is so when you have a beautiful heart, and I'm gonna draw here again, right? Septum, uh, and I'm gonna draw the conductive tissue with this is your blue, this is your SA node. This is gonna be your AV node, and then it goes this way and this way, right? And so these guys have an extra connection here. Okay, if you stop a AV node with a beta blocker or with a calcium channel blocker, okay, well mainly a beta blocker, actually not a calcium, mainly a beta blocker, then this pathway is going to take over and you're going to have an arrhythmia. It's not supposed to, like this area that I'm highlighting with yellow, it's not supposed to be conducted to any electricity because all the shock wave needs to go down your AV node, but it just blocks it, right? The yellow stuff blocks it. These guys have an extra pathway. They like this area is conductive, and when you have a beta blocker that blocks the AV node, you'll get like abnormal electrical activity, and that's associated with the VWP, uh, WPW, uh, WPW syndrome, right? So you don't want to give them a beta blocker. It's C is describing a beta blocker. 40-year-old, not seen a physician for years. Physical examination shows middle-aged man, no obvious distress, yellowish white. Okay. Has some sort of like, he has some sort of hyperlipidemia. Okay. So he's given a statin. Statin, if you want to see if a patient can take it, you gotta look at what? You gotta look at muscle. And okay, so it causes muscle problems, but it also causes hepatotoxicity. Uh, what? Wait, let me make sure if I. Yeah, it causes hepatotoxicity, so you have to. The answer is wrong. I don't know why they think it's in the cap. The answer is wrong. It's liver function test. Liver function test. Because it's hepatotoxic, not renal toxic. There's a diabetic drug, um, metformin. You gotta check renal function for that because that one is eliminated by the kidneys. You also check liver function for that, I think. But statins, you check liver function. That question was wrong. So 70, like it's almost a 70-year-old black guy has a problem and heaves and whatever, diltiazem, furosemide, propranolol. Mm-hmm. So already gets a beta blocker. Improvement of current condition. Already gets a beta blocker, right? Probably C. Probably C. C is just shown to be more effective in like the black population. Yeah, that's what comes to my mind. What is this? Oh, please. One, two. Oh shit, two more questions? Okay, so this question, talk about amiodarone, right? I already saw the answer. So what is trying to quiz? All in all, just explain amiodarone. It's a very, very important drug. Okay. This doesn't really give you much. It just says has a problem. What is amiodarone? Okay, so amiodarone side effects. It makes you blue, right? It has iodine in it. Iodine has in the thyroid. It has interesting properties. It can either make you produce more thyroid or less thyroid than normal. So it causes hyper or hypothyroidism. It can cause either. It's good because it doesn't have the QT prolongations as the other ones. It has like overall, it has like less side effects. These less life-threatening side effects. Those are that's why it's like kind of like drug of choice, like out of the ones that like you see here, you go with. I mean, some of them are wrong. Digoxin isn't used for like ventricular arrhythmias and stuff like that. So a lot of times amiodarone is your like kind of like default choice. 40-year-old comes from Venezuela, opening snap. So he's got what? He's got mm, so opening snap is for chronic rheumatic heart disease, right? So your right ventricle, right atrium calcifies. It looks like a fish mouth. It's tighter than normal, right? So blood accumulates behind it. That makes your left ventricle, left atrium get stronger. Stronger left atrium means what? Means you have hypertrophy of left atrium. That causes um, AFib. That causes AFib, atrial fibrillation. Let's see what the question is asking. Oh yeah, it's talking about atrial fibrillation. Okay, interesting. It says prescribe an antiarrhythmic that has actions in um, all classes. That's amiodarone. I told you amiodarone has action in all classes. Oh, which one of them would make this medication contraindicated? Hypertension, probably alcoholic cirrhosis. To be honest with you, yeah. I mean, you need a liver to. It's a hardcore drug. You need a liver to Dose it properly. Okay, thank God it's done. Gonna upload. Let me do the renal ones from the beginning. Okay, mother of 8-year-old. Nice. Probably minimal changes or post-streptococcal glomerulonephritis. See which one. Or maybe IgA. Wait, what happened? Low albumin and proteinuria. So minimal changes in these. So it's E, right? With E, you only see stuff in electron microscopy and you see effacement of food processes, which means the food processes, if this is like a vessel, this is like the food processes kind of going like this. Effacement means they're like connected to each other. They're like the gaps are gone. Uh, I've explained these. Okay. 53-year-old guy, with super high blood pressure, cardiac arrest, autopsy, markers. So super high blood pressure is associated with fibrinoid necrosis, right? But I don't think that's the answer here. In the context of kidney, the answer is like, actually, I think it is that. Fibrinoid necrosis. The other thing that could be the answer is like the onion shape, the onion shape. Oh, work, bitch. The onion shaped. The answer is wrong, as you can see, 7% of people chose that. The onion, but the answer is B. The onion shaped, so-called um, like vessel problem. It shows like it looks like an onion. This is the inside of vessel. This is I don't know what it's called. You don't need to know what it's called. Usually there's a description of it, not um, what it is. 26-year-old uh, proteinuria, a lot of proteinuria. That's not mild. C3 is depressed. C4 is normal. Probably has lupus. Okay, low C3. Remember, lupus is a type 3, type 4 hypersensitivity, right? So it's type 3 hypersensitivity. It's an antigen. It's your antigen. This is targets binding together, and these guys are just like in your circulation going around, right? The problem with this is, if you remember your antibody, this is your antibody, at its C end, at the constant chain, which is like somewhere around here, it has binding sites for like your immune cells. So it's gonna activate your immune cells, right? Especially when it's binded to to an antigen, right? It's gonna activate your immune cells. It activates your neutrophils a lot. That's activation of neutrophils because of the immune complexes is what leads to damage of the vasculature in type 2 hypersensitivity. What I just described was type 2 hypersensitivity. Okay, and one of the ways that these immune complexes, which is antibodies bind to the antigens, they get picked up by the cell is what? Is via the complement cascade. So that's why they use a lot of the complements, and that's why you get low complements. So that's why lupus and low complements go hand in hand. Now, would you look at that? We have the question about exactly what I described, exactly what the type. This patient has lupus. What's going on? Type 3, and I just described exactly what happens, right? Complements participate, like not complements, complexes, immune complexes. What's an immune complex? It's an antibody and antigen. They participate somewhere, the neutrophils come along, they sense it, they release all their toxic shit because they think there's something wrong. That damages the vasculature or damages the glomeruli. That's the type 3 hypersensitivity. So we got a 55-year-old Uh, call if you pain. Okay, here's it. I didn't know you guys learned about kidney stones. What's a kidney stone? Radio opaque stone in the left ureter. Urease. Oh, we got urease. So this C is associated with UTIs. What the hell? What the hell? Oh, -4. -4. So it's not C. Okay, if it's not C, then the default is B. Default is B. That's like usually, and especially that this person has Crohn's. Okay, so what happens with Crohn's is that it's kind of complicated, but this is your terminal ileum, right? This is the end of your small intestine. You have a lot more fatty acids than you're supposed to. These are your fatty acids. Why? Because they didn't get absorbed. Why? Because you have Crohn's. Uh, Crohn's causes inflammation and like malabsorption, so your fatty acids won't get absorbed. Fatty acids have a negative charge at one end, so they're gonna bind calcium. Now, calcium can usually binds oxalate. It can't anymore because they're bind to fatty acids. Then we have extra oxalate. Extra oxalate gets into the blood. It's usually here, but not anymore. It gets to the blood, then it forms stones in your kidneys. Stones of calcium oxalate. So there's this guy, I'm gonna read it, has a shit ton of proteinuria, diffuse thickening of the basement immune cellularity. So it sounds like membrane proliferative. Uh, Maybe membranous. Wait, let's see what else, what other clues. Sounds like membranous, and it's associated with type B. So what is membranous? It's very similar to what I described with type 3 hypersensitivity with lupus, except this time the antigen antibody complexes is like anti-hepatitis B and like hepatitis B stuff, right? So the same thing happens, but this time damage happens in the glomeruli. And this is kind of similar to what happens in polyarthritis nodosa as well. Again, it's antigen antibody complexes. Let me see if I can just come to a diagnosis. I think this is uh, focal segmental, but I need to read the question. Oh, if I were to choose, I would choose F. Yes, just based on histology. Now, is it a guy with diabetes probably? So that is nephritic syndrome, right? Uh, Actually, they don't describe what if he has diabetes or not. But we know it's nephritic syndrome. Sorry, nephrotic syndrome, because there's only protein in there. And you got these nodules. They have a two-part name. I don't know. It's like something J, like some long ass name. So it's a two-part name. Look it up or whatever for diabetes. Um, so you know it's nephrotic. This causes nephritic. This causes what nephritic is membrane proliferative, I believe. ANCA, they're all nephritic. They cause focal. They cause rapidly progressive glomerulonephritis, the worst type you can have. ANA lupus can cause membranous or membranoproliferative, right? And this also causes, this is like what good pastures, it causes this. Also ANA. ANA, well, this is obviously not membranous because your membrane is normal here, right? It's like there's some areas of thickening, which is, and then you have these fat nodules, which is pretty associated with the know what the name of the nodules are. Are these like I'm telling you, it's a two-part name, and one of them has W. I'm not good with names. I'm good with concepts. That's why I do well on the step exams because they're about concepts, not names. Memorizing names has never helped you, anyone, cure a disease. So play into your strengths. That's what I'm doing. Dark colored urine, 24. Celiac, what could it be? It's IgA, nephropathy. Okay. Wire loops, I think it's membranous proliferative. Splitting of the basement membrane is still membranous proliferative. Mesangial proliferation is also. Is it this? It's IgA nephropathy. How do you know? It's because of celiac disease. Celiac disease is associated with IgA, or also like this, kind of like vasculitis on the arms and legs. Hematuria and proteinuria, so you know it's nephrotic. Mesangial cell proliferation. Subepithelial humps. I guess subepithelial humps. I would go with that honestly, but apparently I don't know. Maybe in your notes it says C. I remember this. I think it's H. I don't know actually, but I can tell you it's focal segmental. Read glomerular sclerosis, right? Uh, they have a lot of protein loss, and that's the thing. It's like focal segmental. So some of the kidneys, that's like 20% of them, are sclerosed, right? I think one of the like, I think it's B. Yeah, know this shows up on exams. It's the amount of um, proteinuria that determines how bad it is. Let's see if I can go based. Hmm, I don't know what's going on here. Oval fat bodies, no hematuria. This looks a little proliferative to me, right? And so I'm gonna go with membranous. Membranous, right? Well, actually, no. This is focal segmental. That's why you get like this. This is the segment of sclerosis over here. And obesity is one of the things that can predispose you to that. Um, A, B, and E cause you give you membranous. Also, you can just be like A, B, and E gives you membranous, like the same thing. Probably D2. So C is the only one that doesn't. Is there a lot left? God damn. Should just ended it. Okay. Honey cluster lesion face. What is this? Strep pneumo, not strep pneumo. Group A strep, right? So what do we get? Group A strep, rheumatoid. I think it's this focus. No, it's subepithelial. Subepithelial. Okay, so endothelial is subendothelial. I think membranous proliferative is the only subendothelial. Um, So your two hardcore nephritics, which is diffuse proliferative or diffuse mm, diffuse segmental glomerulonephritis and membranous proliferative, right? I think out of those, only membranous proliferative has subendothelial, right? That's the vessel side. Most of the other ones that have something is subendothelial. This is an important example of that. So it is spike and dome, it's just not subepithelial, it's subendothelial. It's subepithelial. Maybe it's not spike and dome. I think it's just spike and dome is associated with um, spike and dome is associated with the membrane proliferative and tram tracks and stuff like that. But the sub it has it has bumps or humps. Yeah, it has humps. Yeah, that's like the antigens that accumulate on the subepithelia. So that's where on the podocyte side of things. So this is probably minimal change disease. God damn. Okay, if this was in a young kid, it would be minimal change. Oh, I didn't see the humps. So no, actually, this is electron microscopy. So I thought because electron microscopy is usually used for minimal change disease for diagnosis, is minimal change. But it's not. First of all, you have hematuria, right? You have low C3, right? So these are all membrane proliferative findings, right? Uh, and you also have the bumps. So it's really not membranous, it's membrane proliferative, but it says nephropathy. So I guess membrane proliferative because it's a nephritic syndrome, and that's obvious because we have hematuria, urea. Well, this question is probably a Wilms tumor question, so you just know it's Wilms tumor. Uh, that's the WT1s for Wilms tumor. If they're talking about a kid with a kidney cancer, really, you have Wilms tumor. This question, again, if you have when you have celiac, there's this other thing called herpetiformis dermatitis. It's kind of like itchy lesions, so super itchy lesions on the extensor surfaces. So like these surfaces, these are the flexor surfaces. These are the extensor surfaces. Those are both associated with IgA nephropathy and uh, vasculitis. So it's an IV drug user, right? Probably you were thinking of what? You were thinking of focal segmental. Uh, what else happens? We give them vancomycin and gentamicin. Let's see. So it's cluing at those gentamicin is renotoxic because it's literally toxic to the kidney cells. Now the kidney cells are gonna see the toxin. The first place it's gonna be is like the proximal convoluted tubule. So that's where it gets the most necrosis. Probably B. So, hydronephrosis. Uh, so I said C because I didn't see the uh, fever. I thought it's a so C B would have been right if it's a kidney stone. C is the best answer if you're thinking of infection. Actually, C is also better for kidney stones. I could still be kidney stones because you have mild fever and kidney stones. 65-year-old, dark colored urine. And these dyes, what they do is that they mm, cause really cancer of the urothelial cancer. Now this is renal cell carcinoma. It produces what? Produces your favorite. It produces a lot of things. It produces EPO, so you have high RBCs. It produces parathyroid-like hormone too, so it increases calcium. Okay, this guy has a mutation. This is not good pastures. The other one. Mutation is collagen 4. Um, they basically have a faulty collagen. You got deafness and plus like the kidney symptoms. What's the question for this? Oh, wait, what happened here? All right, I think I'm done actually. What a beautiful feeling. Oh yeah, thank God. I've been up since 5 a.m. I was outside actually. The first part you didn't have my video because I was outside. It was dark out. Now it's like 8:14. Okay, I hope this helps. I mean, the questions aren't the best, and they focus on the type of detail that like it's not really important. So some of them I'm like I really I don't know this. So I apologize if there's like stuff that I didn't know, but I hope like through answering these questions I showed you how I think of these questions and um, hopefully that's more valuable than like answering the questions because you gotta start building your like senses. And I think the best way to do that is to like kind of like do questions with someone with the right like I guess senses. Like I don't know how to describe it, but it's kind of your sixth sense that you develop doing medical questions. It's like it's more than just a knowledge. It's like synthesizing medical information into like it's like the science part of medicine that make it different than anything else that's not a science basically. But hopefully you see like how I think of questions when I see questions, what comes to my mind. And a lot of it is just like knowing your content. And but my biggest tip to you is to do a lot of questions and try to do questions that have explanations. Because if they don't have explanations, then what's the point? You can't really like go around finding explanations. It's a waste of your time. Um, if the MCQs don't have good explanations, don't do them. Like this is not it's not useful for you to do them if they don't have explanations. The best part of a question bank is that it has explanations. When I was in term 4, around where you are, I bought AMBOSS and I did AMBOSS, and AMBOSS questions are really hard, but that helped me a lot. I, yeah, I can't recommend it enough. It's really hard, but that helped me a lot. Okay. I'm gonna close this and do some amboss actually.